Okay, well, why don't we get started? As you know, this is our second session of industry-sponsored Grand Rounds. The first one was on cranial, and it was about a month ago. And this one here is on spine. And we'll have mostly spine-focused talks. I wanted to thank our speakers who are listed here and the different topics that they will be covering. First and foremost, I wanted to thank our industry partners and sponsors that include Excellis, Bespoke Technologies, Sentinel Spine, Therapeutics, DePuy Synthes, Eminent, Globus, Medtronic, OSS Design, Phasor, who has a booth inside here, Providence Medical Technology, Synara MedTech, Spinex, Stryker, Surgeon Tech, Surgical Theater, and that's it. So we'll get again, thank you to our partners, and Dr. Yurkov's already here.
Thank you, good morning. Kind of an off-topic, really, overall presentation, but just more to highlight some of the partners that we have here supporting us, and take us maybe through a little bit of a history as well. So what is it? I'm close to 5 years out now, but not so long ago. We've been drilling out these fabulas for every single ACDF case. When Dr. Vanu was here, I was very particular about how you drill it, what angle you hold your instrument at, and you pretty much had to machine the whole thing to a perfect low dowel. Dr. Levy, you still use this, right? A lot of times? Okay, so yeah, I have that next as well. But yeah, this was the main source of our implants. So you can see this $20 dowel will pretty much run the whole industry, right, for ACDF. But of course, it's changing. Here's one of the cases I did pretty much coming out of residency, four-level ACDF. Not sure how much it was indicated, but the lady did well. Then you wonder, why do people like allograft? It's a very friendly material, right? Infectious disease doctors love it when you don't put any metal in any infectious cases. So there were a couple of cases where we really pushed the limit, and maybe should have done something that should not have been done, but got away with it, putting those standalone cages just by themselves, allograft, drilled out of fibula, stuck it in the infected space, and just hope that it doesn't pop out or break. And both seem to have fused, so I guess there's that inflammatory profile of any discitis osteomyelitis that may promote bone growth overall. But of course, this is not a structural support, right? So that's why you get this, look at the kyphotic deformity over time, even though it fuses, but it's not really a favorable biomechanical feature to just apply to every single case. Medtronic was smart. They machined the pre-cut bone allograft, and I think that's what Dr. Levy is using then, right? These things there. So same material as allograft, you just don't have to do any work now during the surgery, waste your time cutting it out. Put yourself at risk with that sharp blade. And it works just as well. And of course, the whole biomaterial market had been exploding, and that's what all these companies are presenting at all times. ACDF is more of a, you want to say, kind of on the background, quiet branch in terms of implant industry, but there's a lot of advances that are happening. Here are just different sources. You can have PEEK, you can have titanium coating on the PEEK implant, carbon fiber that DePuy had. We tried that. And the idea started with radiolucency and how much you can see it. A lot of people don't want to see where they put the implant or show where they put the implant. That way, these type of transparent implants, you just place them, you see they have the little markers, but overall they look okay. Even though if you look closer, you can see how those markers are way on the outside, but still, a bird's eye view kind of hides away those imperfections, right? So that's what I guess some people prefer these type of invisible cages. And of course, titanium, it's becoming more and more, I think, of standard of implant material. It's more available, easy to produce, easy to work with, great infectious profile. So we have multiple papers now on how titanium does with an infection that doesn't really grow biofilm and it's safe to use. But now, of course, it creates a lot more artifact probably. You can see it a lot more. You can see it during the implantation, especially in those tough spaces where the shoulders and all the other bones get in the way and you can't get it right, a lateral x-ray. But then you also pay for it when you're trying to get a post-op MRI, and sometimes the artifact is too heavy. And here are some of companies that have the 3D printed titanium. You guys, some of you have met Brad Sudica from Oaktree. He's based out of Tampa, and he's kind of opened up the facilities for any of you guys. If you have any prototypes you want to build or anything like that you want to explore within the 3D printing world, he's open to it. And not like he just wants to steal your idea. He doesn't do that. He's just a nice guy like that. We have Eminent Spine here that's supporting today's event. They've put up a lab, and they've been very forthcoming and supportive overall, but they also have the 3D printed titanium. And you can see what 3D printing does. On the top right, the machined titanium that looks nice and smooth versus 3D printed that has that trabeculation. You can really make it the inside anything you want, because you just designed it within the 3D world. You can make it as close looking to the bone as possible, and some believe that fools the bone cells of growing bone into it. Who knows? Here's how some of the videos from the 3D printing. It's cool. You can see the powder layer that was layered at about 10 microns. Then the laser goes in and micro welds that layer on the previous layer. How they create implants, and it's out of titanium, which is just how these implants come out. Imagine, I don't want to say the old days, but they're still pretty much today's day. You think of building something and you're like, okay, now I want to make this thing, but how am I going to cut things out? And who's going to make it for me? Who's got all the machines? Not anymore. You can draw up the 3D CAD image of anything, send it in, and you get your prototype right there. And of course, there's been a lot of papers now looking at different things. Does it all make a difference if you put bone, titanium, PEEK, carbon fiber? And pretty much, when properly done, there's no real difference in fusion rates, complication rates. Pretty much, you put a structural thing into the disk space, right? And it seems to be just all fusing the same. And it comes down to personal choice, financial decisions, costs, and all of that now. Standalone cage is something that I've been using now since the beginning for all of my one-level ACDF cases. I've been using a standalone of one sort or the other. And Samed and Victor actually been doing a prospective study since 2021 now, right? Or at least that's when they wanted to finish that project. We're looking at all of these cases and how they do so far. I guess with a recoil bias and a subjective kind of a view, I have not had a single case where I regretted putting a standalone, or I said, oh man, we should have put a plate in, or this failed because it's a standalone. They seem to be working well. For a single level ACDF, 2 levels, I would use a plate, of course. But they're a great bailout on some of the revision cases because of low profile, not requiring to take out the previous hardware. For instance, look at the top right. Patient has had a 3-level ACDF, an additional level. Would be impossible to put a plate on top of this without doing something with this current metal, right? And so now something that would have been a bigger surgery turned out into just a very focal, targeted operation that's much quicker, and it works. It hasn't failed. And you have some other examples here of just different revision surgeries, either adjacent levels or 2 levels above, levels above and below at the same time. I find it's a great option for kind of a single level surgeries. And of course, the complication that we have to deal with, right? Pseudoarthrosis. You can perform a great surgery, but something happens, whatever factors are, patient factors, surgical factors, technique, a level does not fuse. This was one of our cases from last year. Patient came from outside with a history of 3-level ACDF. Bottom level did not fuse. It's already a couple of years out, probably not going to fuse anymore, so no more point in waiting. And options are going in there, removing everything, re-drilling, putting new cage, and kind of promoting the fusion again. Or as one of the sponsors here with Providence, they have this product, very interesting, that tray on the right, pretty much everything you need for the surgery. It comes in all pre-packed. And here, Sumit doing the operation. And you can see me, I'm pretty much bored. That's how simple that surgery is. With biplanar X-ray, even Sumit can do it. But there are just a bunch of cannulas that go over into the space, into the facet joint, place a spacer, place a graft, and promote the fusion. Does it work? We'll see. Don't have enough follow-up, but surgery itself is pretty straightforward, considering otherwise the revision you'd have to go through. It's a same-day operation, 2 little stab wounds, and patients go home, and our patient was happy overall. This is her post-op later, how these implants look within the facet joints. They haven't spread out yet. Of course, the biologic market, you can see we have several stents out there talking about the new ways of producing biomaterial that can promote fusion. It's either, as always, conductive or inductive materials, and everyone tries to stay away from something that gets bad if the freezer goes cold, goes warm. Something does not require a lot of storage, logistics. So that's where the push is. This is not a cervical case, but just to demonstrate currently that the company that we have here on one of the tables, Surgeon Tech, they've been very forthcoming and easy to work with in terms of adapting some of their technology to what at least I've needed. And so here's their gun that can deliver that graft into any space pretty much in a minimally invasive fashion. So that opens up a lot of opportunities. You remember my previous talks when they do transpedicular approaches to Charcot joints or minimally invasive access to those inflamed disc spaces. And for someone who's sick and you don't want to do a big operation, but you're trying to reinforce the disc space with some graft and promote fusion, maybe this is an option. Same thing with the cervical. Will it come down when you do those cannulated approach to the facet joints? Do you need something like this? Who knows, right? But that's where the future is probably going to go. Less invasive options of putting that bone graft in. And of course, don't forget our arthroplasty options. And the beauty of our place is that we have all these companies that have access. And then we can just really, in training, try it all out, see different steps, in follow-up, study them and see if they make a difference in different mechanisms. For instance, you have NuVasive's M6 with that mobile implant that I think biomechanically replicates a real disc the most because the center of articulation shifts, which is what happens in real life as well, as opposed to static rotational implants that other companies have. But that's why I think it's important not to let hospital administrations to kind of try and limit these companies, because then we'd be blocked off from the rest of the world and just work with the same group. And we really want to have that flexibility, Dr. Levy, right? Well, I think that's it for this just quick short talk. Thank you, guys.
Thank you, Tim. So the next, if we could put up the slides, is I feel it's more like a commercial rather than like a talk on implants and that, and then we'll get back on track with some of our other speakers. And I wanted to thank Ben Klein, who was our summer scholar last year from University of Toledo, and who helped me put together some of these slides. So. You know, the question is social media for spine surgeons, or for anyone, in fact, is it really worth the trouble? So I think everybody understands what social media is. We have numerous different platforms: TikTok, Instagram, Twitter, now known as X. And basically the definition is any online forum that allows group communication through text, audio, images, and or video, and each of these platforms are more focused on one area versus the other. And it's been around for a long time, like 25 plus years. And you can see the start of social media in 1997, and when these different platforms became available, and we'll talk a little bit about some of the older platforms and where they went. But I mean, it is not only in Miami or the US or North America, but you know, everybody around the world uses social media. In fact, more than half the population of the world has a social media account. So if you don't have any at this point, you're kind of a little bit behind the times, I would tell you. And in terms of focusing in on our surgical specialties, there are certain surgical specialties that tend to use it more. And certainly plastic surgery is one of the elite specialties in social media, but neurosurgery is definitely up there. And this is a paper in JAMA talking about which accounts that neurosurgeons typically use. And we certainly have a lot of famous people in neurosurgery who are huge social media pushers. And this is nationally with Chris Graffio, and this is 2 years old, it may have changed, who is number one. He's a vascular neurosurgeon in orthopedics. Many of these people, like I said, are very senior. They're not necessarily junior people. And I can tell you within our institution, the two biggest users faculty-wise, at least for Twitter, are Mike Ivan and Bobby Stark. I know Rick has a huge Instagram account, but when you look at neurosurgeons and seeing the age who are the top users and which social media platforms, you can see it's mostly like 35 to 54, which is my age group. And you're not supposed to be laughing at that. And then which accounts are Twitter, LinkedIn, and Instagram. Those are like the three top accounts that are being used by neurosurgeons. And Turkey, who's in the back there, did a great article, tons of work, lots of help, but basically looked and tried to answer the question, within neurosurgery, which universities tend to have more social media presence? And the answer is the larger, university centers had more social media presence. And then there's lots of information in there, but the two pieces that I'm pulling out is then which subspecialties are the highest users of social media? And the answer is, not surprisingly, vascular and skull base, and spine, peripheral nerve is like way at the bottom in terms of presence. And so this talk sort of came from a debate that I had at the American Academy of Neurosurgery, where my colleague, Dr. Ho, who is the chairman of neurosurgery at University of Florida, was taking the pro stance, and I was taking the negative stance. And he talked about, how social media was great for attracting patients, marketing that was very cost effective. It stayed engaged with existing patients. It built your reputation, all of this kind of stuff that he felt was like super important. And I was telling him that he was crazy and that these are all of the bad things that happen on social media. And these are like the 10 reasons why you should not be involved in social media. And we'll go over them one by one. But I think one of the most important ones, and you could see it here this morning with Dr. Yurikov's talk potentially, is that a lot of people will literally take images in the operating room of a patient who's literally not even awake yet, has got staples in, and goes, look at me, I just did this. This is awesome. You should be doing this. There's no follow-up. There's no mention of complications. What were the outcomes? And so just to put that into perspective, not for the spine world, but for the vascular world, this guy, Walid Brinky, who I'm a huge fan, even though he's in a different specialty, this guy is very special. He's always sort of thinking out of the box. He basically put a paper together looking at posts for embolectomies after stroke, and looking at the outcome of social media versus the outcome of tried and true published trials in endovascular therapy for stroke. And the results were like this. I mean, whatever's posted, everybody did great, and there were no complications. And if you look at the trials, there's obviously not everybody does great, and there are complications associated with it. So what happens is, people look at social media and go, oh, this is what I should be doing. This is great. It's not necessarily truth. And the trustworthiness of social media is being very much reviewed. And it makes sense because there's no peer review. You could put whatever you want, and nobody will ever question about the misinformation. And so here's some data about misinformation on social media. The other big thing is, and I'll show you this video that hits home with many people here who kind of are aware of it. And then we'll talk a little bit about it. And I think it's super important for all of the trainees that are sitting here. So let's just go over this video, and the person has been de-identified so that you won't know who this person is.
Press charges.
Can you call 911, please? She's getting
Yeah,
violent.
call 911. Oh, yeah.
Let him
Call
go.
911.
This is the video that has a lot of people talking on social media. An Uber driver attacked in Brickell. And we've learned that the woman in that video is a neurology resident at Jackson Health System.
And she's now on administrative leave as the company investigates.
Things get heated. She knees him. He pushes her away. She falls, then decides to get in the car. The driver on the phone, presumably telling police he is in front of Rosa Mexicano in Brickell.
Sometimes you are a beautiful person, but one day you have a bad day.
And so if there's anything that's important in this talk, it's this beautiful lady and what she just said. I'm going to repeat it for you.
Sometimes you are a beautiful person, but one day you have a bad day.
Right. And so basically what happened in this particular case, which was like 6 or 7 years ago, I walked into a room where my colleague, who was the chair of this person, and he looked like he'd seen a ghost. And I was like, what's wrong with you? What happened? He goes, Alan, every night I go to bed and my prime thing is to clear my inbox. Every night I go to my bed and I know my inbox is completely clear and everything's good. I woke up like I always do at 4:30 in the morning, and I had 3,500 emails in my inbox, and I knew it was going to be a really bad day. And basically I was getting texted because, is this neurology, neurosurgery? It's not really clear who's involved, and people from Australia were texting me within 3 hours saying, what's going on at Jackson? Like, what are you guys doing, type of thing. So the long and short of it was, this person, who I think all of the physicians felt like that they should be able to retain their job, because this is like obviously there's unprofessionalism here, obviously there's alcohol here involved, but it's one mistake, and that should not make a career ending thing. And unfortunately the hospital, who's the employer, which is Jackson Memorial, did not feel that way. And then ultimately that person was let go. So what you have on social media is subject to everybody looking at. In fact, we have a division in neurosurgery led by Dr. Yurikov, which is the Division of Social Media Investigation, DSMI. And so that anybody who applies for either a job or during resident interviews, he's usually sitting there quietly in the background, looking at people's social media presence. And so not only do we make decisions, but everybody makes decisions based on what's out there in social media. Dr. Yurikov, any comments about this? Or bad stuff? So you use discretion in deciding what content you post online. Use your SoMe portfolio as a resource, and it's certainly admission into medical or professional programs is now people look at that. What about time? Time is so precious, and I think a lot of people spend an enormous amount of time on social media. It's actually addictive. And in fact, when they did a survey of neurosurgeons on social media, 26% would spend 1 to 3 hours per day on social media. That's like crazy. And you probably go, well, that's not me. But if you actually take your telephone and you swipe right, you can see how much time you spend on email, social media, Twitter and stuff. So Eva, why don't you swipe right on your phone right now and tell me how much time you spend on social media this week? So, and this is just some of the examples of what's very simple to get from your phone, so you can keep track of what you're doing. And there's certainly a lot of examples. Neurosurgery. This is an example in plastic surgery who live streamed a procedure that she was doing on TikTok, and basically she lost her license. There was a dentist who was literally performing a dental procedure while he was while he was being investigated in court, and had that streamed on TikTok. So there's privacy issues, huge privacy issues, and at U Health we have a certain policy of what can be used and what can be posted, and everything requires consent and consent from the patient. And you cannot go on the assumption that, oh, I'm in the emergency department, here's a cool image of some guy who's got like a spear in his eyeball, and that would be really cool to post this on social media, because people will know based on, even if it's like a peripheral nerve injury or a fracture, they can track back on the day that it was posted and go back and say, well, that's my leg or my injury, my shark bite. And so even if you think it's de-identified, it's not de-identified. People can go back and track, what was posted. And if you don't have permission, that can get you in trouble. Certainly a lot of court cases have hinged on things that people have put on social media. So again, available. This is again a local example from about a decade ago, where we had the bath salts eating homeless guy who ate the face off of some other homeless guy. And basically that one of the, I think Gen Surge residents posted that picture of the emergency visit on social media. These are some local examples that you can get off the news. Jackson Memorial, HCA, where people had taken pictures and then it got backtracked to understanding where those pictures came from, and then there were legal suits that resulted from it. One of my biggest bugaboos about the social media is the whole concept of what I call scratching the surface. And you tell me if you are one of these people. So, in general, the War and Peace, right? Everybody here has read that book. It's about 3.25 pounds. It's about I think 5,000 pages, a little bit of light reading. But if you read the book, that means something, right? But a lot of times it's like, well, you know what? I didn't read the book, but I did see the movie, and I thought the movie was pretty good. That's like obviously a 3-hour commitment. And now we're sort of like, I didn't read the book, didn't see the movie, but I did see the Twitter post, and so that makes me an expert in War and Peace. Well, I think the same thing is true of what happens in journals and education. So, the way that we used to do it as residents is that a paper would come out, we would actually read the entire paper, the references, we would check the references, and then we would come up with a conclusion about what was being written. These days, I think a lot of what happens is that people will just read the abstract and the conclusion and not read the paper and feel like they're expert in, whatever was written. And unfortunately, it's gotten to the point where people just read the tweet about the article and feel like that's all they need to do in terms of, Dr. Shaw, yes? Yes. Okay. So the other thing is this whole thing about fear of missing out, also known as FOMO or FOMOMO. There's lots of different names, but it's basically, and it's a very real thing. It's basically the anxiety that you feel when you're on social media watching people having rewarding experiences. And those rewarding experiences could be anything from doing like a really cool surgery, and you're like, wow, that surgery's so cool, I wish I could do that surgery. You know, I feel bad about myself because I'm not doing that surgery. Or like, you know, when we have these fantastic weekends and we post them, and other universities are like, why am I not at Miami? I'm at University of Chicago and it sucks and it's cold here, and I wish I was at University of Miami. Or, you know, I got a publication in Science or Nature, and, you know, I just published in Curious, and, you know, boy, Gellerizada is, you know, she's making me feel bad because she's getting all these high-level publications, and how come I'm not like her? So this is the whole thing about FOMO, and it makes you feel bad. There's censorship and hazing issues. People have posted stuff, and then people push back on their concepts. It's more in the political realm, but it's not uncommon. And I've seen fights over social media about some prominent spine surgeons, who I will not mention their names, that, you know, have literally been fighting on social media about the results of a procedure. And then there's this whole thing about social media instability. You know, we know that 6 Degrees, Vine, Friendsters, those were social media platforms that existed in the past that are of no significance anymore. And Twitter. And so just, you know, a lot of people have invested a ton of time on these platforms, you know, getting their following. If one day they woke up and X didn't exist, you know, that would be huge, because it's all this time investment that doesn't exist anymore. So something to definitely consider: social media instability. As a result of FOMO, you know, you can have sleep and psychological disturbances, and that's been well documented in a number of papers. And then, you know, just taking it to the extreme, and there's this author, Andrew Keen, who's written about all of the bad stuff that results from internet and social media. And this is a line from his book, which I did not read, but I did see the post on social media, which says that out of this anarchy, it suddenly became clear that what was governing the infinite monkeys now inputting away on the social media was the law of digital Darwinism, the survival of the loudest and the most opinionated. Under these rules, the only way to intellectually prevail is by infinite filibustering. So it is sort of illustrating the fact that, you know, a lot of people are loud, but there's, you know, no content, and that's a concern for the survival of our species.
Social media, it can be overwhelming.
So the conclusion is, the world is becoming ever more reliant on social media and technology. It's important to recognize the risk and potential harms that come with being a neurosurgeon who is active on social media. That's all I got. We're going to go back to talking about real things, instrumentation, and how to facilitate your practice. Who's next? Dr. Birks? Awesome.
Good morning, and thank you, Dr. Levy, and thank you to our sponsors today. I was out there hearing about all the new technologies. This particular technology I'm going to talk about is not here today, but so I'll be able to give you an objective approach, as I also don't have any royalties or conflicts with this company. I did have some support with this talk from these two individuals sharing some slides. So, you know, we're talking about spinal oncology, and we have to assure what the diagnosis is with a biopsy. This takes a multidisciplinary approach, and then the treatment involves radiation, chemo, and surgery in the majority of these cases. And, you know, we recently started this Spine Onc conference one Monday every month, which has been really nice and educational, but sometimes it's tough in oncology. As my colleagues know, in the cranial side, these cases have to move relatively quickly. You have to make decisions quickly and speak to people. So I may not be able to wait till the next month to present at a conference. Spinal metastases are very common. 1.9 million new cancer cases every year, with 10 to 20% of these with symptomatic vertebral mets, depending on how you look. Greater than 20,000 cases of spinal cord compression in the US. Survival depends on a few factors, and I just presented some of Mass Gen's stuff here, which is the SORG questionnaire, where you can basically go onto their website and type in all the things about the patient, and they'll tell you exactly how long the patient's going to live for, basically. So if you're ever interested in a consult case, you know, and this is for spinal oncology, they have these decision-making criteria for a bunch of different disease processes, and they've shown that it can reliably predict survival, and they validated this study, and that's kind of the latest thing, is to validate these decision-making criteria. So the goals for metastatic spinal tumors are pain control, reversal, prevention, neurologic compromise, local control, a combination of the above. Most patients with metastatic disease to the spine never reach the surgeon. They're managed just with chemo and radiation. And we talked about the incidence of the metastatic tumors. Now, primary tumors of the spine, this is much more rare, and benign tumors are more common. The surgical treatment of these may involve en-bloc surgery, and these are some of the indications for that. Let's talk about some of the other aspects we don't often think about outside of the surgery. So the vast majority of these cases will require adjuvant treatment, and radiation becomes particularly important in controlling the tumor around the spinal cord. So how does radiation work? And this is a nice little review from Kubitschek that I've adapted to our audience. But basically, radiation works by damaging the DNA of cells, and for the most part, normal cells have a better capacity to repair DNA damage than cancer cells. Here's sort of as you escalate the dose of radiation, you get more death of the tumor than the normal tissue, because the normal tissue can sort of recover their DNA and repair it. Here's just an idea of what sort of the typical radiation treatments are in the radon side. For prostate, it's 40 fractions, with delivering 2 gray at each fraction, and that's sort of similar. That's sort of what we think about with conventional radiation, these low radiation doses, but over many, many fractions, which is kind of the safest way to radiate a patient, because it allows the normal cells to repair their DNA. As you start getting up to very high doses of radiation, now you have to be very precise with your delivery, because obviously that's going to cause more damage to normal tissue as well. So just as an extreme example, if you look at Gamma Knife, they're giving Gamma Knife for trigeminal neuralgia gives a single dose of 85 gray. So there's a huge spectrum here of how much we're delivering. Typically in this radiosurgery for spine world, we're talking about 12 gray delivered up to 3 fractions or so. So just found that to be interesting and some good background for all of us. So what are we giving radiation with? Usually it's photon radiation, but we do have a proton beam machine at UM. The cool thing about protons is they have this Bragg peak where they don't have this exit dose of radiation. So you can the radiation is delivered in a more precise manner, and that's sort of shown here in this figure. Proton radiation is a great option for targets near critical structures in cases we want to avoid the exit dose on the normal tissues. Chordoma and the base of the skull and spine are great cases for proton radiation. Typically, how is radiation shaped? And it's using this process referred to, it's using a linear accelerator, which is what is depicted here in the process known as intensity modulated radiation therapy. This is the HyperArc machine. I'll show you basically what a plan looks like here, where the HyperArc spins around and it delivers doses at different angles so that the target area is getting a high dose of radiation. That's sort of what that looks like. That's the IMRT. This is what the workhorse of radiation therapy is. Here's what I just went over to UM the other day. Here's what the proton beam looks like. It's massive. You've probably never even seen this, but it's humongous in the back of UM, multi-million-dollar project, and here's what the patient sees. It looks like something out of Star Trek where you're going off into space, but that's how protons are delivered at UM. Here's our sort of like the heat map for the radiation in a sarcoma case. So what's radiosurgery? This is nearly identical to MRT, but it uses a higher dose per fraction, fewer number of fractions, and it allows for pinpoint precision. SRS and SBRT are both sort of names for types of radiosurgery, and that just means fewer fractions. That's basically what that means. So an SRS plan is depicted here. This is a patient of Dr. Kubitschek's where they radiated this lung lesion, and you can see it sort of melting away with high-dose radiation. And if you're in the Bilski lecture, he talks about this, basically being able to use low, like single fraction and high-dose radiation is very effective. But that's where you kind of see the complications of radiosurgery. I mean, complications of radiation as well, just to bear that in mind. And so we looked at that, radiosurgery, conventional radiation. This is a concept I just wanted to talk about, the biologically equivalent dose. It's calculated using this complex equation that the radiation oncologist plug the numbers in. It has to do with time and several other things. But basically, you can see they create a biologic equivalent dose. If you're giving 3 gray in 10 fractions, the biologic equivalent dose is only 32. Whereas 12 gray in 2 fractions, the biologic equivalent dose is 44, because you're not giving the cells time to repair and you're hitting them with a higher individual dose. Why not for every case? Well, I mean, because of some of the issues we talked about, it's more labor intensive. It can cause damage to the normal structures if you can't pinpoint the accuracy very well. And in spine, we're typically using it for oligometastatic disease. Usually it's maybe 3 mets or less is where we're using spinal radiosurgery. It can't be done in cases where the tumor is touching the spinal cord, and now this is where we talk about separation surgery. Titanium hardware can limit the use of SRS, and that's sort of what I'm going to talk about with this carbon fiber hardware. This is this company. They shared some of their data with me. Yeah. So basically, this is the patient pathway per them, and now you can see that using some of their. I just want to show you some of their figures. So typically, what's done if you can't see around the titanium is getting a CT myelogram. But even with that, you can have artifact. And here's a comparison of titanium and a carbon fiber screw there on the right, and you can see very little artifact there. And this paper here just shows that if you get the patient into radiation within 40 days of surgery, they have better local control of their tumor in general. And this was published in Neurosurgery in 2021. Here's a real example of carbon fiber and an MRI done in a patient. You can see very precisely within the spinal canal. So it enables radiation oncologists to be able to treat and use radiosurgery after a surgical case, where probably what they're doing is using more conventional treatments, conventional IMRT, if they don't see the tumor very well because of the titanium. Here's another example, found that planning and delivery of SBRT with carbon fiber instrumentation on the CyberKnife was within expected ranges of the normal spine, basically showing that it did not distort their planning at all. So basically, this is somewhat driven by the radiation oncologist to say, hey, we really need to be able to deliver high-dose radiation after surgery. Can you please try putting in, stuff that's not going to cause so much artifact? And this is just another illustration of that. Here's a pretty cool figure that they shared with me. Basically, there's this tumor around the pedicle, and you can see that you'd be able to target that very nicely with a radiosurgery dose. And this is the comparison. We've all seen this. And so, one thing we ran into is just like the availability of a CT myelogram, because honestly, that shouldn't be that difficult to get either. So that's another story we need to talk to radiology about. But that is basically what you would do instead, is get a CT myelogram if you can't see what's going on. Since they're not here, I do want to bring up just the downsides. Sorry to Icotech, but I think it's an amazing technology. Right now, I think the main prohibitive thing is the cost. This is why it's not available at Jackson. The screws are very expensive, but you got to think about it in terms of the whole spectrum here. If you use a sponge of BMP, that's sort of one thing that we can always benchmark ourselves to, is the cost of that is roughly equivalent to this. So I just calculated sort of what it would cost, the cost differential. So then I think the hybrid construct is an option where you're using carbon fiber just at the location of the tumor, and maybe carbon fiber rods or titanium rods, carbon fiber screws at the site of the tumor ×4 maybe, and then titanium screws above and below. So anyway, that's everything, and I appreciate everyone's time. Yeah, I'm sure wound issues would be likely complication, as those are already sort of an issue for these patients. But I haven't looked into that specifically. I know Hornacek was doing that for a while. He talks about that a lot. I'm not honestly sure, but yeah, maybe for like a primary tumor of the spine where you really want to, do a curative treatment on it. Yeah.
All right. Good morning, everyone. Can you guys see my slides and hear me here? Yes. Perfect. Okay, perfect. So my apologies. I'm not there in person. I'm presenting from my clinic here in Boca Raton. But today I'm going to be talking to you about biomaterials in spinal fusion. Here are my disclosures. So I think the first point is what is a biomaterial? You've heard a lot of people here already talking about biomaterials. It's a substance that's been engineered to interact with biologic systems for medical purpose, either therapeutic or diagnostic. So when you think about categories, you can, broadly divide it into synthetic biomedical and biological biomaterials. And, like Dr. Birx was talking about these particular screws. You heard Dr. Yurikov talking about all the different types and materials of implants. I think one of the last talks I gave to this group, I focused on the implant side of biomaterials. So we talked about, modulus of elasticity and titanium and PEEK and all these things. Today, we're going to focus on biologics. Now, I'm going to be giving kind of an overview of this topic and going into some background. And you'll see, hopefully this dovetails nicely with Dr. Cummings' talk, where he's going to go into some of the specifics of some of the new technologies. But, I think one thing you should notice is that almost every speaker today is talking about biomaterials in one way or another. And that'll just give you an indication of the relevance of this topic in our world today. And so I think for me, I need to start with an important point. And that is a lot of us kind of, in my mind, use a misnomer. And I say this to patients all the time. I say, what I'm going to do in surgery is not really a fusion. It's a set you up for fusion. And what I mean by that is, by putting screws and rods in a patient, you're not guaranteeing that that patient is going to fuse. They may fuse, they may not fuse. If they don't, it's what we call pseudoarthrosis, right? So the fusion doesn't actually happen in the surgery. It happens later when they go home, and it takes months and months. And so I think that point is important because as residents and as trainees and fellows, we spend a lot of time thinking about and focusing on putting into hardware. So, if screws look good and implant looks good, we feel good. But that's really just a small part of the kind of total puzzle in terms of, getting that patient better. And I just put a little red arrow here on the left where you see this is what we want to see, which is that bridging bone, across the disc space or across the transverse processes. So, pseudoarthrosis, how often does it happen? These numbers here are very low, in my opinion. This is a large database study, queried New York, California, Florida, Washington, healthcare cost and utilization. And they show for cervical fusions, 1.2%, for thoracic or lumbar, 1.8%. Obviously, I'll show you some other studies that show much higher rates, and it obviously depends on what kind of a fusion. If you lump, single level lumbar fusions in with multi-level, it's going to show a lower rate. Obviously, the multi-level and the scoliosis surgeries have a higher rate of pseudoarthrosis. We know that there's a lot of factors that affect this, tobacco use, NSAIDs, steroids, all these things. These are kind of self-evident things. But I wanted to show you other publications that show much higher rates, just for you guys to be kind of grounded that this is a real problem. This is another study that looks at a number of sub-studies, and you can see, fusion success rates ranging from, 65% up to 96%. So you can imagine the non-union rates are somewhere in that neighborhood. And, again, this is like a 30-minute talk. I'm not going to go into this, but you could look, and there's, numerous studies talking about this, approaching it from different angles, looking at cervical, looking at lumbar, looking at deformity, understanding, how different implants affect this whole thing. But I think when you drill down into this, and when we start really thinking about this concept of arthrodesis and fusion, we need to understand what the conditions are that help to create a fusion. And this is a particular study that it kind of outlines these, and I like the way they talk about this. I think the first is physical manipulation of the site. So you can think about that as when we decorticate the transverse process, or when we scrape the end plate and get bleeding bone. That's to expose those osteogenic stem cells. Stimulation of those stem cells to migrate to the fusion site. That we have some osteoinductive signals that match the cell population lineage, and those are, we want obviously these osteoblasts to form bone, and that we create the low strain mechanical environment. That is the component when we put screws and rods and interbody cages. And whenever we do a fusion, we place some sort of grafting material to occupy the desired site of fusion. And so today's talk is going to be focused on that grafting material and the different kinds. And obviously that fusion occurs when those osteogenic response causes bone to kind of bridge and integrate those graft materials across the patient's native bone. And so when we think about, what are ideal materials to promote fusion, there's generally people say like the holy grail would be to have 3 different components. And there's 4 that I've listed here, but the 3 that people talk about are that it's osteoinductive. And I think you heard Dr. Yurkov mention that's osteoconductive and osteogenic. What is osteoinduction? It's basically when immature pluripotent stem cells are recruited and stimulated to develop into these free osteoblasts. Osteoconduction is just bone growth on the surface. So obviously a very, this is osteoinductive, it should be osteoconductive. A very osteoconductive surface is one that promotes growth on the surface, but also into channels and pores. And that's when you start thinking about these, 3D printed cages that we're using that have all this porous microarchitecture. Osteogenesis is obviously the process of bone formation. And then again, osseointegration is really that fusion process. It's kind of self-explanatory. So if you think about like what would be the most osteoinductive substance, would be like if you could inject a substance into soft tissue and it would form bone, that would obviously be evidence that this is highly osteoinductive. And this is an example of that from one study where they basically injected BMP7 into soft tissue, and you could see that after 19 days, it begins to form bone. So highly osteoinductive, and we'll talk a little bit about BMP. So, I'm not here to suggest that all these biologics are like the answer to fusion, but they're a part of the part of the solution, right? So screws are part of the solution, interbody cages are part of the solution. The biomaterial we use in those interbody cages and screws is part, and biologics are certainly, I believe, and I think most of us believe, are an important part. So what are the options? There's a lot, so you can imagine we're not going to spend a ton of time on each of these. I think Dr. Kumick will go into more detail on a couple of the sub choices here, but you have autograft, allograft cellular bone matrices, which are abbreviated as ACBMs, DBM, which is demineralized bone matrix. We have ceramics, mesenchymal stem cells, BMP, and now I-factor, also known as peptide 15. So a lot of choices. And I think, again, as trainees, we kind of like whatever, the attending says they want, we just put it in there. But I think it's important to understand what each of these, the positives and the negatives. So autograft has often been kind of the gold standard historically. I think, a lot of us are very familiar using local autograft. So for example, you do a laminectomy, you bite off spinous process, we morselize it, we put it. But I think, we probably get less experience harvesting autograft from the iliac crest. But, when you think about this autograft, there's basically 2 components, and this is true of any bone, of course. The cancellous bone, which has structure, the cortical bone, which has structure, enhanced mechanical properties, and the cancellous bone, which of course has the cellular diversity and activity. That's the part that houses the bone marrow. Clear advantages. Obviously, there's no immunologic reaction, with autograft, so that's very nice. Lower rate of infection. It does have these inherent osteoinductive properties with these cells within them. I'm going to talk a little bit about that in a moment. But a lot of us are not commonly harvesting iliac crest autograft because it's not necessarily free, and there's going to be donor site morbidity, there's going to be pain, the risk of infection there, scarring, and obviously it's a limited quantity. You can get a reasonable amount of grafting material from there, but if you're talking about, for example, a scoliosis surgery, you're not going to be able to get enough autograft for that particular type of surgery. So even though it's a gold standard, the reality is it's probably not as rich in osteoprogenitors as we'd like to think. There's been a lot of studies on this, and actually a lot of these osteoprogenitors don't survive the grafting process. The level of matrix factors vary significantly across patients. We talked about the graft site morbidity. And again, if you're just using cortical autograft, that's not having significant conductive factors. So, the summary of this is today, obviously local autograft, if it's not an infection, if it's not a tumor, that's kind of a no-brainer. We're all going to do that. Iliac crest, most of us are reserving for patients who have infections or previous non-unions. And again, if we keep, drilling into this deeper and deeper, there's, other types of autograft that are being used today in patients with very significant infections. Some people are using autograft that's attached to a vascular pedicle and things like that. So there are kind of other options here. The next one we'll go to is allograft. I think everybody here has seen this in the operating room. The picture on the right is kind of a corticocancellous, which is a mix of cortical and cancellous bone. This is, of course, bone transferred from a human donor. And, this is like, we can think of this as a much lesser version of our autograft. It's just got the conductive properties, but it doesn't have any of the progenitor cells, really no osteoinduction. And so most of us are using this in conjunction with autograft. I think very few people would just put allograft on its own unless there really was no other option. But, it has clear advantages. You can get as much of it as you want. I think it's rare that you'd not be able to get enough allograft from your operating room. It's relatively cheap. But again, you have to use it with autograft. There is, a higher risk of resorption. This is obviously not vascular. It's just kind of inert bone material. There is a higher rate of infection seen with allograft in general. And I put this asterisk of biocompatibility issues. I don't think any of us who are using allograft in OR in general are seeing biocompatibility, but you have to think about allograft as being on a long spectrum here. And that spectrum of immune response depends on the type of allograft used. I don't think any of us right now in spine surgery are using fresh allograft bone, but that has been used by orthopedics and joint replacements. The next one that has the next highest level of immunologic response would be fresh frozen allograft. Most of us are using freeze-dried allograft. This is kind of most of the surface proteins that cause that immunologic reaction are not present on that. So I think, rarely are we seeing any immunologic reaction with this kind of a material in our surgeries today. So the next one is allograft cellular bone matrices. And, a lot of us would just call this cellular allograft. This has become a very popular product. There's a number of different versions of it. I'm sure a number of our vendors that are there today can talk to you about their particular product. But it's basically a combination of allograft, of DBM, which I'll talk to you about in a minute, which is demineralized bone matrix, of osteoprogenitor cells and mesenchymal stem cells. And so what's the advantage? Well, theoretically, it's got all of those three critical components that we talked about: osteoconductive, osteoinductive, osteogenic components. But the disadvantage is that it's expensive. And the reality is right now we don't have strong clinical evidence. Now, that doesn't mean that it's not helpful, but it does mean that there's probably more research that needs to be done. This is just one particular review of the literature that I put up here. And I can send this all to you guys if you want to kind of drill into these. But basically, there are very few objective, unbiased, in other words, not sponsored human clinical studies that show its either effectiveness or superiority in spinal fusion. So I think there definitely needs to be more studies on this. The reality is, I think I certainly utilize this, and you can think about, cases where you're going to want to use this. You think about like a tumor case, like a metastatic tumor where you're doing a decompression. You can't use that local autograft because there's tumor there. You don't want to put allograft on its own. And so a lot of us would say, okay, well, theoretically, it's better than allograft because it has all these other components. But, does that theoretical benefit bear out? I think remains to be seen. The next one we'll talk about is DBM, or demineralized bone matrix. And this is somewhere kind of in between. It's allograft that has some osteoinductive components to it, along with the obvious osteoconductive components from its structural part. But basically, this is created by acid extraction of the mineralized human bone that allows it to retain the collagen fibers. And it has varying amounts of BMP, growth factors. And, I think that varying amount is key. Not all of the DBMs are the same, and each of them has different components, and that will be part of the problem in trying to decide which DBM is you should be using and which one you shouldn't. But, again, it's abundantly available. It does contain some of these proteins and growth factors, doesn't contain the live cells like the ACBMs do. But again, there's this issue of variability in composition. What is the literature on this show? In general, most of the literature on DBM is using DBM in conjunction with autograft, and it does show that in that particular context, it's effective, at least as effective as autograft. So I think, you know, DBM is something that many of us are comfortable using, and I think there's good literature using it as what, you know, you could call it a fusion extender, you know, again, as a composite. Next topic is ceramics. Now, remember, when we talk about biomaterials, there's the synthetic ones, and then there's the biologic ones. Ceramic is obviously a synthetic, and it's, you know, composed of components that you'd often see in natural bone: hydroxyapatite, calcium sulfate or phosphate, more commonly calcium phosphate, because the calcium sulfate is more prone to reabsorption, and collagen. Again, this is a purely osteoconductive substance that's readily available, easy to sterilize, no immunologic reaction, and it comes in various different forms. I've showed 3 of them on the right here. I'm not picking any particular product. I'm just showing you guys examples. But it doesn't have osteoinductive properties. So I think that's why you can think about using this. A lot of people that would use this would think about using it with stem cells. In other words, you can harvest stem cells from bone marrow, you can aspirate that, and you can kind of impregnate the ceramic with it and use that. And I know, you know, where I did my medical school at Tufts, that was kind of the preferred product. They would take ceramics, they would take some stem cells from the iliac crest, they would pour it over that, and then they would place that. And so then you get the osteoconductive part of the ceramic with the osteoinductive of the stem cells. You know, obviously the stem cells on their own are only osteoinductive. They lack the conductive component. You know, the clear benefit here is that, you know, these are stem cells with multilineage cellular potential, growth factors. But again, there's varying concentrations of progenitor cells. And just to put this up here as a reference, you know, if you guys are interested in this topic and thinking about doing this, it's not as simple as like put a needle in the iliac crest or put a needle in the pedicle and just aspirate and keep aspirating until you get 5 or 10 cc's. This is a nice paper, of course, by our own Dr. Wang, and it just talks about, you know, proper technique when obtaining this. And basically, you should be going every 1 centimeter, aspirating 1 or 2 cc's, turning 180 degrees, and then going another centimeter deep. And the reason behind that is if you stay in one spot and you just aspirate continuously, you're basically going to get a little bit of bone marrow and then a lot of just blood. So your actual mesenchymal stem cells are going to be very dilute. So this is just something to keep in mind when you're thinking about this particular topic. BMP, I think BMP here at Miami is something that we're very comfortable with. I think we probably have a much easier time using BMP than other institutions. I think a lot of other places restrict its use, not because it's not effective, because it's expensive. So here it kind of flows pretty freely, at least for the moment. We'll see how long that lasts for. But what are BMPs? They're basically soluble cytokines that are involved in differentiation, maturation, and proliferation of precursor cells into osteogenic cells. You know, any of you that have scrubbed spine cases, which is probably anybody from PGY1 all the way up, will know that when we're getting ready to do our fusion or to put in our cage, we'll say cook the BMP. What does that mean? Well, you see it on the right. Basically, what you do is you take that BMP, and usually a typical vial of BMP is 1.05 milligrams of BMP, and they squirt that onto these collagen sponges. And why do we do that? We do that because if you were to just pour that BMP into the wound, it would diffuse all over the place. You wouldn't be able to control it. And by putting it on that sponge, it's able to control it and keep it in that particular area where you want it. So for example, if you're decorticating your transverse processes, you place your sponge there, theoretically that BMP should mostly stay in that particular area where you place it. Clear advantages in terms of fusion rates. It's FDA approved for ALIF, but 85% of its use is off-label. You know, we commonly use it for posterior lateral fusions here, for TLIFs. What are the disadvantages? I mentioned the cost. It's associated with seroma formation, ectopic bone, osteolysis. There's a potential risk of increased cancer. I'll talk to you about that in a second, and postoperative radiculitis. So just going into this BMP and cancer, I think there was a lot of early concern that BMP could lead to postoperative cancer formation. And this was kind of based on this idea that if you expose tumor cells, local tumor cells to BMP, it could promote growth of pre-existing oncologic cells. So I think most of us today would, I don't think anybody here would like be doing a tumor case where they're resecting local tumor in the spine and place BMP in that area. The real question is, does it cause distant cancer? And there was an early higher dose of BMP, Amplify, that was denied FDA approval because of this and because of some early studies. Again, fortunately, we're at a place that has a lot of experience with this. This is a very nice paper by Dr. Levy. And, you know, you really need to read the paper. I'm not going to try to do the social media thing, as Dr. Levy mentioned, to just show you the summary of findings. But basically, you know, there is not a lot of literature that shows that a BMP is associated with distant cancer. some of the literature that does show that cancer it happens in the first 2 years and not after that. And as you think about that, we'd really be expecting that to happen over time. So, I show one study here, which was the Amplify trial that didn't include a second component of that trial that showed an increased incidence of cancer. But really, in almost all the other studies, there was not good evidence of distant cancer. So I think the answer here is you have to be thoughtful, obviously, about this and your use of BMP. Again, most of us would not use it with local cancer. If a patient had a distant history of a basal cell carcinoma of the skin, I think a lot of us would probably use it in the spine, but I think it's up to you. Obviously, there's a medical legal component given the fact that it's being used off label. I think the last thing I want to talk about BMP is that definitely as a resident, I think a lot of us don't spend enough time thinking about how much BMP to use. And once you become an attending, that's going to be you. You got to answer that question. And again, fortunately, we're at a place that has looked at this very carefully. Very nice paper by Dr. Levy and Dr. Hofstetter, basically looking at, as you increase dose of BMP, do you get added effect? Or are you just getting, the downsides of the BMP, like the increased stroma formation without any additional higher rate of fusion? And the answer is yes, there are levels above which you're not getting added benefit and you're only getting the downside. So it's pretty well established here. If you read this paper, it goes through each individual type of surgery and what the recommended BMP dose is. For myself, I use this as a guideline in my practice. So I think this is a very, very useful paper in a practical sense. And so the last one I'm going to touch on is I-Factor. And Dr. Kumuk will be talking about this, I think, a lot more than I am. But this is something that I've started using a lot more myself lately. And basically, this is, again, an anorganic bone matrix, which is your osteoconductive component, combined with P15 peptide. What does that peptide do? It basically mimics the cell binding domain of type 1 human collagen for osteogenic cells. And when they bind to that, it triggers synthesis of extracellular matrix and growth factors. There's no literature on this having an effect on cancer, at least right now. So this would be a good substance to use in those particular cases. But it is only FDA approved for single level ACDF between C3 and C7, but it is cheaper than BMP. At least the early literature on ACDF shows equivalent fusion rates. Again, but I think we need more literature on this, long-term studies to understand risk. But I am beginning to use it, and I've seen some very nice results in my practice. We'll see how that bears out long-term. This is, again, just that study on using it for cervical cases. So finally, I think the important thing to consider when you're considering what type of biologic to use, to not use this one-size-fits-all approach, to actually understand the literature, the positives and the negatives of each of these particular grafting materials, the quantity you should use, how you should obtain that. Often you're combining biologics, and I think that can lead to very, very nice results for the patient. Thank you guys so much. Appreciate it.
Okay. So it was a great talk by Dr. Basil, and I'm going to be covering a little bit about what he said, but then doing a little bit deeper dive on some of these topics that he was talking about. My name is Matthew Kumuk. I'm an assistant professor here at University of Miami. And here are my disclosures. And I firstly just want to say, echo what Dr. Levy said. Thank you so much to all of our sponsors. Without you all, we wouldn't be able to do this today. So there's really a lot of great items out there. So anyways, take your time and explore them and get your hands on them. So when I was first given this opportunity to give this talk, I was pretty excited because, spine biologics, we focus a lot on the instrumentation, as you can see in that image there on the left. There's a lot of really amazing instrumentation that's come out over the past couple decades, 3D printed porous titanium now, sometimes with nanotechnology to try and increase the amount of scaffold for these bone cells to grab onto and grow through. But really, we don't talk as much about the cement or these biologics that goes through that inner body and that metal. And so when I think about these things, I think about it just like in construction. You have rebar, and then you have cement, rebar being obviously the inner body, and the cement being the biologic, whatever it goes in there. You can't have one without the other, and they both work homogeneously together. And so really picking that best biologic for whatever need that may be is incredibly, incredibly important. So I know Dr. Basil touched on this just briefly, and I will as well. 3 main bone graft properties: osteoinduction, genesis, and conduction. Can get a little complicated as can the field of biologics. So I'm going to try and keep it as simple as possible. So osteoinduction, it's the signal, it's the thing that recruits more mesenchymal cells and stimulation into osteoblasts. So the signal is the most important thing there. Osteogenesis is the cell itself, usually found in autograft, and we'll talk a little bit more about that in a second. And osteoconduction is the matrix, the thing that the actual cells bind onto and grow new bone through. So again, the current landscape of biologics is very complex. I know we saw a little bit of that with Dr. Basil's talk. Here's a list of many different type of the biologics, as you can see here, and we try and categorize them. Sometimes the categories have even changed over the past decade or two. And a lot of that is predetermined, as well as kind of how these biologics were approved, their mechanisms of action, their supportive clinical evidence, and it can get pretty complicated. Within these areas of regulatory pathways for which these biologics have gotten approved, some of them are easier to get approved than others. I will just say, and what I've highlighted down there is that the most studied, highest level of approval are these class 3 drug device combination products that have undergone investigational device exemption or pre-market approval. And that would include BMP2 and P15 cellular attachment and activation peptides. And again, those are devices, or not devices, those are products that have undergone level 1 evidence with the highest level. So the classes, again, Dr. Basil talked a little bit about that. We're going to briefly touch on those as well. Autograft, allograft, cellular, growth factors, and synthetics. Let's do a deeper dive in each one. Autograft, the person's own bone, advantages, no histocompatibility or disease transmission issues. These hold all 3 components of bone growth: osteoconductive, inductive, and genic. There's perceived low cost. It is essentially the gold standard for what we use now. Disadvantages, iliac crest bone graft complications and increased operation time. That can also include other surgical risks like fracture, cosmetic deformity, numbness from injury to the cluneal nerves, hematoma formation. And sometimes it's been studied that donor site pain can be up to 34% of patients, with even unacceptable severity in up to 3% of patients. Okay. Allografts and cellular grafts, okay. This would include things like DBMs, our structural allograft, cortical bone chips, allograft rings, blocks, and also cellular allografts here, such as Osteocel, Vivigen, and ViBone. And the advantages is these are osteoinductive. These are the cellular allografts are theoretically osteogenic as well, okay. These are coming from human bone. And the disadvantages is, these are donated human tissues. They always carry a risk. These are screened, not sterilized. If they were sterilized, they would remove all the properties that they're trying to maintain, such as those osteogenic properties. As we can see, as I'll show you in the next slide, there's a tremendous amount of variability in the quality from lot to lot. And some of these allografts, the cellular allografts, are not very well regulated. They have a frozen supply chain. So they have to be maintained in very strict conditions. So DBM, I thought it was very interesting. It was first isolated in 1965 and then clinically available in the 1990s. Again, these are things prepared by acid extraction, reducing the antigenicity, but trying to preserve some of those osteoconductive and inductive properties. So some of the inherent BMP2 and BMP7 that's already in the tissues. DBM, again, osteoconductive, osteoinductive. However, these levels vary greatly between manufacturer lots, donors, and manufacturers. I thought this was a great paper that looked at a few different types of DBM, as you can see there. And then that CV on the right, which is the coefficient of variation. This is looking at the differences in variation between different lots from the same manufacturer, the amount of BMP2 and BMP7. You have as much to 97% in one lot, down to 30% in the next lot. I'm reading that top line, and 28.2% in the third lot. So that's a difference of a coefficient of variation of about 76%, which is tremendously different depending on what lot you get on what day. Clinical evidence, how well does it work? Specifically for DBM, you know, there's limited level 1 evidence for DBM, graft-on DBM, and specifically has been mixed with allograft. Allograft has been examined in 3 randomized controlled trials. I'll just highlight the last RCT there on the bottom when it was studied in 2012 for posterior lateral fusion in 46 patients. At 2 years, there was an 86% fusion rate compared to 92% in iliac crest bone graft. So it works, you know, pretty well. But obviously, some of the previous studies, there was some variable information. Okay, cellular-based allografts, looking at their clinical evidence, you know, there's no known level 1 studies on cellular-based allograft. There was a study. Let's see, this was in 2022 from the Trinity Elite Matrix. This was an uncontrolled prospective multi-center open label trial that looked at lumbar fusion in 274 patients. And at 1 year, they found there was a 90.5% rate of fusion. Osteocell, we use a fair amount of that here at UM and some of our other sites. You know, there's some great evidence there, but it's not the highest level as far as level 1 studies. Okay, moving on, synthetics. Synthetics, the examples include VITAS, the ATRAX, some of this Nanos, ActiFuse, iFactor, and later on that we'll be talking about is OsteoZyme as well. So it's an interesting area. In the 1990s, they discovered that marine invertebrate corals shared a similar microscopic porous structure with bone, and therefore synthetics/ceramics were named after these corals. And so it includes things like tricalcium phosphate, calcium carbonate, and hydroxy apatite. And it's usually recommended for use as a bone graft extender, meaning it's just originally developed as osteoconductive, meaning the matrix, the actual matrix around for which the bone cells grow onto. So they would combine it with autograft, bone marrow aspirate, and BMP. But we're going to see later on that that's generally not the case as we're moving forward, and some of these synthetics have become kind of next level synthetics and with osteoinductive components. So advantages, they're readily available. There's no risk of disease transmission. They're very cost effective. You know, and again, their efficacy just continues to improve. And I'll talk about that in a little bit. Disadvantages, there's a lot of them on the market. They traditionally have been perceived, again, just as a scaffold or osteoconductive material. Clinical evidence, there's limited level 1 evidence for synthetics, randomized controlled trial with using ATRAX putty. This was from 2020. Posterior lateral fusion rate at 1 year, ATRAX putty 55%, iliac crest local autograft 52%. So pretty good, obviously comparing the two. Growth factors. So this category includes things like BMP, and as Dr. Basil touched on a little bit, these are biological compounds that induce the transformation of mesenchymal stem cells into osteoblasts, so osteoinduction, increasing that signal. But BMP, as we saw, has the potential to induce ectopic bone formation. Wherever it goes, it's going to make bone. It's made using recombinant DNA technology, so it's incredibly effective. It's very well studied, as we'll show on the next slide. Disadvantages, it is expensive. We will look at some of those complications, and as I highlighted there, number 1, a carrier matrix is required to retain the soluble factor at the graft site, so to prevent the BMP from diffusing around into the adjacent tissues. So we usually place it onto a collagen patty first. So clinical evidence, there's been multiple level 1 clinical trials supporting the efficacy and promoting fusion. It was approved in 2002 by the FDA. Mainly came from this study by Burkus, which is a multi-center prospective randomized non-blinded 2-year study. It was for 279 patients that underwent ALIF with tapered threaded cages. 143 patients received the BMP on the absorbable collagen sponge, and then the control group, 136 patients received autologous iliac crest bone graft. Infuse or BMP fusion rate at 2 years was 94.5%, and the iliac crest autograft was 88.7%. So we can't talk about BMP without talking a little bit about their complications. And when BMP first came out, some of the data that I showed in the early 2000s, BMP was bringing home approximately $900 million a year. And then all of these talks about or issues with potential complications started coming out. And so that had to be further studied. So its use actually decreased down to about $450 million a year. So really took a hit on obviously that product, as it should have, and for these issues to be better studied. And here's a great paper that summarizes some of those issues for heterotopic bone formation, radiculitis, and potential dysphagia. And I know Dr. Basil talked a little bit about that risk for cancer, which has been very well studied, and really the increased risk for cancer has been inconclusive. So with all of these biologics, these were summarized into guidelines in 2005 that came out in the Journal of Neurosurgery Spine. And those were updated in 2014 to include some of this expanding field of biologics. I know that's pretty small to see there. However, most of it, highlighting some of the grade 1, level 1 evidence there, it really says even at that point, some of these things are inconclusive. And certainly this is from 2014, so a decade ago. So I think we're time for, or overdue for an update. So in the end, what's the ideal biologic, circling back after we've reviewed some of these different things? Here's some of the different types of autograft. Clearly, autograft is the gold standard. If we could match the osteogenic cells, osteoinductivity and conductivity of autograft, we could have this perfect biologic, all the while trying to decrease the risk of complications. And I think as we move forward, there's this burgeoning world of kind of more advanced synthetics. Synthetics, again, were first introduced as just a matrix or a carrier, and now they're becoming they're being utilized in introducing osteoinductive properties to these synthetics. One such category of that is peptide-based grafts, and these were based on biochemistry developed in the 90s. And the premise of this is a peptide bone graft is to exploit the natural biological activities of mesenchymal stem cells and their osteoblastic lineages to initiate the regenerative process of new bone formation. So basically osteoinductive. They study this obviously a lot, and in rabbit intramuscular implant studies of this P15 peptide, they established that the P15 does not support bone formation outside a bony tissue environment, basically no ectopic bone formation, which is obviously very different than our BMP that we talked about before. So it's not just a synthetic scaffold as many of the traditional synthetics were. One specific type is this I-factor P15. It's a 15 amino acid sequence found on human type 1 collagen. This facilitates attachment to bone forming cells and activation of osteogenic cells. So it's osteo-inducing. And it's really, their slogan there is attaching, activating, and accelerating. And this was approved in 2015 for ACDF, single level ACDF surgery. They do have, they're one of, it's BMP and essentially this P15 I-factor peptide that have level 1 trial evidence that showed superiority and overall success versus local autograft. This was done in 2016 with I-factor fusion rate, 2 years, 97.3% versus 94.4% in local autograft. And they do have an extended 6-year follow-up as well. I think their next generation, which I'm excited for when it arrives here, it's already out, unfortunately, in Canada. I'm not sure how it got there first, but it's the P15 osteogenic cell binding peptide combined with a collagen carrier for better handling. Currently, it's part of a hydrogel. So you have to bind it with something to kind of get it to where you want it to stay, because it has the potential for kind of diffusing out. So I'll be looking forward to when that comes out. Another next generation synthetic would be this OsteoZyme Catalyst, another product that I wanted to talk about. And it's using, again, traditional synthetics, more osteoconductive, just having that matrix. And now, through their combination of nanoarchitecture and the increased silicate ions, they have found that their product engages a dual zone pathway to bone formation. So traditionally, it would just be this intermembranous vascular formation that you'd see here on the edges of the graft. And through their combination of these two things, again, the nanoarchitecture and the increased silicate ions, have they found that it does a osteoinduction of the endochondral bone formation here at the center. So it really upregulates endogenous BMP to start forming more bone. So there are a lot of other synthetics. Some of them have some similar components. So what makes this one different? This one has a different physical composition. It's nanocrystalline and with nano architecture. So it has an incredibly high surface area for protein absorption and cell adhesion, up to 4 times greater when compared to some of the other synthetics. For, as you'll see a little bit later, it's unsintered, so it's developed at lower temperatures, leading to a softer material. So it's very nice and very malleable. Wherever you put it, it stays. It's a very nice putty. And why is smaller better? So it's getting closer to the crystalline nanostructure of bone, as you can see here. The second component is, why is this product different than some of the other synthetics, or for the other synthetics that have silicate ions? It has the highest level of substituted silicate in any bone graft. It's 20 times greater silicate release than a different product such as Actifuse. And silicate ions, I'm not going to go down that road for this talk, but they've been proven to have a positive effect on osteogenesis. So this is what I showed before. We see an upregulation of the endogenous BMPs through this osteoinduction for bone growth. So it's not just a matrix anymore. So this is the handling properties that I was talking about before, something you don't think about as much until you start utilizing these things in your cases. I prefer putty. It goes where you stay, wherever you put it. We found that we've been able to mix this product very well with autograft that was harvested during the operation. We put them back in syringes and then putting them in different areas, such as for posterior lateral fusion. It stays exactly where you want it. It doesn't diffuse out. So we've been very, very happy with that. And most importantly, does it work? So all the earlier studies have showed that yes, it works very well. There is a new study out with this product. This is out recently, and again, studied 14 patients with a 12-month follow-up through TLIFs. And I think the most important thing here, as we look at, and they looked at the rates of fusion over 3 months, 6 months, and 12 months. And then the percentage of people that were fused at 3 months are 29%. Okay, at 6 months, 64%, and at 1 year, 93%. But I thought what was very interesting was partial fusion was already occurring in about 73% of people at 3 months. And all the patients did well as far as improvements in their ODI and VAS scores, and there was no device-related adverse events. So again, just a summary of this product I thought was novel, kind of that next generation synthetic that really utilizes nanosurface attraction plus the ionic amplification that other products do have, but they have their own increased amount of that. And that changes these synthetics from something that's not just osteoconductive, but improving on the osteoinductivity as well. Thank you so much. I think that's it. Don't forget to check out the sponsors. Thank you so much.